Hello, everybody, and I'd like to welcome you to our latest Outbreak Management Advisory Board. And thank you to all members of the board for giving up their time for an extra meeting that we scheduled. And similarly, a welcome to everybody watching live or watching after the meeting. It should be a slightly shorter meeting than normal, as I said, because it's an extra meeting that we've added in just to receive some important updates and to follow on the discussions that we had last month. So the first agenda item is normally to do any welcomes and apologies. So I'll ask Tracy to just highlight any apologies that we've had, please.
Thank you, Chair. Yes, we have apologies from Ian Floyd at the Council, Ian Humphreys from First York, Phil Metton from the CCG, Simon Padfield from Public Health England, Sharon Stoltz from CYC, and Mike Padgham from the Independent Care Group, as along with his sub, Bev Proctor, who can't come either. Thank you.
Thank you very much for those, Tracy. That I know will be recorded. Obviously, welcome, as I said, to everybody else. The first formal agenda item is then declarations of interest. So I'll just give a couple of seconds in case anybody wanted to indicate to me that they wanted to give any additional declarations. If not, as far as I can see, no extra declarations to declare. That then takes us on to agenda item 2, which is the minutes of the previous meeting. So that was a meeting that we had on the 7th of July. There were no actions arising beyond having this extra meeting that we're now having. So just to check if you were happy to sign off those minutes, like in previous meetings, if you do not raise a hand, shout or wave at me, I'll assume that you're happy with those minutes. So thank you very much for that. That takes us straight on to agenda item 3, which is the presentation on the current situation with COVID. And Peter is joining us today. So I'll hand straight over to Peter, who is our public health consultant. Peter.
Thanks very much, Chair. I'll just wait, hopefully, for those slides to appear. Wonderful. So a bit of a data update to give board members a sense of the current picture for COVID cases in York. I will leave any data or information on vaccination to a further item. So this will cover cases of COVID. We are now obviously in stage 4 of the national plan for reopening. So a lot of the restrictions have lifted. And as board members will be able to see, the curve that's presented charts York's journey story, I guess, through this pandemic in terms of cases. The early upward shift last March in cases of COVID is likely to be a huge underestimation, given that testing was at the start of the pandemic restricted for people who are severely in hospital. But you can see from more recent peaks of COVID cases in York in October, in January, that we have had substantial numbers peaking at over 1,400 cases in 1 week back in January. That rapidly came down, and in between March and June, I think it's fair to say quite a low level of infection within the community and transmission in York. And then as stage 3 and 4 of the national reopening programme came through and restrictions were eased, and in conjunction with the rise of a more transmissible variant, the Delta variant, we did go up in cases. Went up rather rapidly and peaked at sort of just around the 500 per 100,000 cases in one 7-day period about a month and a half ago, then came down and have hovered and now seem to have reached a little bit of a stasis at around the 300 to 400 cases per 100,000. And as you can see, the most recent data that's presented, that's validated here, shows that York is at 343.1 cases per 100,000, which is slightly above the national average, but slightly below the regional average at this time. So that's, over 700 cases every week in York. Still quite a large amount of COVID infection, I'm sure we'll all agree, in terms of cases, people getting symptomatic enough to test positive and seek a test. The next slide, if we can, please. Are we able to get to the next slide? Is that proving a difficulty?
Yeah, there's sometimes a bit of a delay. I'm looking at the next slide now, but it might be
okay. Well, oh, there we go. Thank you very much. Cheers. So that places us lower than the regional average as a local authority, and we are looking at that broken down by age, and particularly those older individuals over 60 for whom COVID is often an infection with severe consequences. And as you can see, that is tracked pretty much with the rates of infection across most of the pandemic, but very happily since March and April-ish, as the vaccination program has really started to affect from a population level, rates in the over 60s have been consistently lower than the general population, and indeed are still today. But that doesn't mean they haven't gone up with our recent upswing, and as you can see, we're at 190 cases per 100,000 residents in the over 60 bracket, so that's 95 cases. Again, there we're talking about essentially the same level as regional and slightly higher than the national average, so certainly one to be aware of. This is certainly not a disease which is gone from that age range. Next slide, if we could. Might be a slight gap as we do each of these slides. I don't know if others can see them moving, but I haven't seen it move yet. Has that gone on, Richard? Just checking.
Yeah, I can see the third slide.
Well, it's obviously my internet then. So I'll give a little indication, maybe 10 seconds before I'm ready to move on. This actually, we could probably move on to the next slide, because this just shows 111 triages. Fairly consistent with infection rates, that people are calling 111 to ask about symptoms. At the same time, that rates are going up. But as was seen in that graph, that's a trend which has gone down across time as people get more familiar with the symptoms, but also obviously using sort of NHS online, 111 online. So the trend isn't that noticeable anymore, and certainly at the moment not a high level of 111 use. This graph covers hospital admissions or other people in hospital currently with COVID infection, and as you can see, it has crept gradually up and has stabilized at between sort of 20 and 30 cases, and these data are only ever taken at one point in time. And recently, and I'm sure Lucy will be able to speak to this a little bit more later on in terms of the impact of the hospital, your cases have been broadly between 20 and 30 on the York site, and at the moment, the latest data, we had 4 people in intensive care who are diagnosed with COVID. Not all of these will have been admitted because they have a COVID infection leading to the need of hospital admission. Some may have tested positive subsequent to being admitted. Not all patients in York Hospital as well are City of York Council residents, and of course it covers a wider catchment than merely the council area. But I think it's fair to say that people are still getting severely ill with COVID. Again, many will be unvaccinated. Some still will be vaccinated because the vaccine is not 100% perfect. But the estimates that are coming from the research are suggesting that there is something like a 10 to 11 time difference between the hospital admission rates for those who are vaccinated and those who are not. So sort of in the order of magnitude of 10 to 11 times more likely that you would be admitted to hospital if you're not vaccinated and get COVID than if you were vaccinated. And the next slide would be great, if that's okay. Thank you very much. And as I was saying, these are just a point in time in terms of the hospital beds, and so there may be more up-to-date data as things come through. I'll just wait for these slides to change. So the next slide talks a little bit about excess death, and this is important because not all deaths due to COVID are attributed to COVID. Not everyone has got tested at every stage during the pandemic. And this graph is essentially showing that there were two real moments where deaths were significantly higher in York than we can see from the background rate of death over a 5-year period. Obviously last March and again at the start of this year in the January to March period. That's not the case anymore. So actually, since the sort of the start of March, deaths in York, we have seen fewer deaths for most weeks than we would have expected given the 5-year national 5-year York averages. And in recent weeks, we have seen very few deaths within 28 days of a COVID positive test. We have seen one in the last week, and there was a death around about 2 to 3 months ago. Apart from that, we haven't had any within 28 days, and excess deaths not measuring that much higher. Next slide, please. We obviously keep on monitoring this, and excess deaths are something that as a public health team, we have been monitoring as part of sort of our public health duties to try and understand all causes of death, and obviously understanding as we go into winter what the gap between a winter and a summer death would be, because there are other respiratory viruses apart from COVID. Next slide, if that's possible. This gives the age breakdown for our COVID cases. Back in May or June, we saw a very large peak in our probably you'd say 15 to 25-year-old cases. That in the last couple of months has become more widespread through the age bands, and as you can see, there are definitely good numbers of COVID cases in people in their 40s, in their 50s and 60s in York, but still the peak age range is the 15 to 19 age range. So those including those who are in education, and there will be a number within that age range who are not currently in education, some who will be of university age, but obviously those of university age in the 20 to 24 and upwards age brackets too. It does seem to be predominantly still, however, a disease which is transmitting more against those who are less likely to be vaccinated. So you can see that this essentially does curve downwards as you go up through the ages, and our vaccination rates curve upwards as you go up through the ages, due to people having longer to have taken up the offer of the vaccination as they get older, which is what would be expected during an epidemic where we have a working vaccine and are rolling it out. Next slide, if that's okay. It also gives the number of cases on that slide for information, the raw numbers, but then of course the blue bars are the 7-day rates, which helps us understand some of our age brackets are quite a bit bigger in York, particularly 20 to 24 age bracket is that much bigger. Hopefully the slides are on their way to changing. And apologies if everyone else can see them changing and I can't, but my internet is possibly that little bit slower. Still waiting for those to change. Hopefully it's coming. Thank you. Cheers, Richard. Testing my ad-libbing skills here. This is the contact tracing data. So our public health team for probably around 8 or 9 months now have been actively contact tracing contacts, or rather, sorry, COVID cases, and ascertaining their contacts in an effort to try and contain the virus and stop the chains of transmission. We estimate that hundreds of chains of transmission have been broken through this work, and what we've seen consistently is that since we began contact tracing, quite a high success rate of doing it locally has been shown. As you can see, there have been some weeks where we've been successful in reaching nearly 100% of all cases of COVID. That enables us to give them good advice about isolation, to signpost them to the grants and the support that is available when you are in your isolation period, but also crucially to gather information on where they've been, to look backwards about sources of COVID, whether that be a venue or whether it be a household or social gathering, but then look forward as well. Who have they been with during their infectious period, and can we contact those people too in order to ask them to isolate? Contact tracing is still with us. On the 16th of August, some of the rules were changed about self-isolation, but it is still very clear and very important to emphasize that if you have COVID, you are still required by law to isolate for the 10 days. And there are certain groups of people who are contacts of a COVID case who are exempt now from that, particularly those under the age of 18 years and 6 months, and those who have been vaccinated with 2 jabs and are 14 days post their vaccination. But if you fall out of those categories, then you should still isolate if you've been identified by test and trace as a contact. And as you can see, we are still doing this local contact tracing and still achieving quite high success rates. We can change the slide now. The last slide, if from my memory, talks a little bit about testing, and as well as the public health team keeping on contact tracing, beg your pardon, no, it doesn't, talks about our contact tracing numbers, which is just a different way of showing the previous slide, which talks a little bit about the numbers that we are contact tracing per week, not the success rates. We can go to the next slide. Talking about testing, we're still carrying on 2 types of testing in the city, and important to be clear on this as well. If you have symptoms of COVID, you need to get yourself a PCR test, book on during the national system, but we're encouraging as many people as possible to take regular lateral flow tests when they don't have symptoms. Lateral flow being really a red light. As a test, it's not a particularly good green light. And that's been recognised nationally. So you should still be cautious and follow all the national restrictions, but it is a very good red light, so it picks up positive cases very well. And thus the council has been working on to bring lots of ways to get testing out to people. The LFD testing numbers are presented in this, and it's quite a complex graph with lots of stories to tell. A few things we'd note is that when schools went back in March after having a period of closure due to lockdown, return to school testing meant that our school testing figures went up considerably. We expect that will be the same in the next few weeks as schools prepare for the return in September, and the contingency framework and all it talks about in terms of the testing for schools will mean that the numbers will go up there. Our home testing routes have continue to rise actually, and people do seem to be still ordering home testing kits, clicking and collecting from the various venues in York. That has meant that the numbers that we've seen previously at our testing venues have gone down for direct testing, but there is still quite a large number of people who do like to come and get the test assisted. People maybe don't feel that confident to do it at home, people for whom they'd like to have someone observe them, do the test and get the advice on it, and have become a regular habit for them, which is brilliant. So we have a number of venues you can do that in the city. And I think that is the last slide, Chair, unless I'm mistaken. So I'll hand back to you.
Thank you very much for that, Peter. Open the item for any questions or comments, and obviously it's a report to note with that update. I'll first go to Charlie.
Thank you, Keith, and thank you, Peter, for the report. One thing that gets raised with me quite often is long COVID. And I recognise the medical profession doesn't have a hard and fast definition for this or a hard and fast treatment for it. But do you have any sense of the extent of the problem? And is it of such an extent that would merit a combination of expertise in the city to offer a long COVID clinic?
Thanks, Charlie, for that question. And we've probably got two people who can help answer that question. They're cool. I can give it a go, but Steph may be able to help too. But because it's definitely something in which there is active work going on. There was government money for both long COVID support within primary care in the community and also within acute trusts, often linked to respiratory networks at Humber Coast and Vale level. For us, it's our respiratory network. So there definitely is a lot of work going on. And indeed, we do have long COVID clinics within the local healthcare system for people who do have persistent symptoms. The definitions that are being used, that have been agreed on, I agree that they're not perfect at all, and the treatment's certainly not guaranteed, but the definitions that are being used are to have three types of COVID in a way: the acute COVID that is up to 4 weeks worth of symptoms, which is essentially just COVID, symptoms which persist between 4 and 12 weeks, and symptoms which persist longer than 12 weeks, and that plus clinical assessment of severity of symptoms will be the marker of whether someone receives support from the specialist within hospital, or it's a primary care based offer. And I would also flag the Your COVID Recovery website, which is a national offer, which also offers lots of support for people who are not sure what their symptoms mean, who would like to understand a little bit more. And in terms of the scale, the estimates are showing that it's potentially around 10% of people whose symptoms persist longer than 4 weeks, and 1 to 2% whose symptoms persist longer than 12 weeks. The difficulty is looking locally to see if that's borne out in the figures, and also some more recent sort of anecdotal surveys showing that might be an underestimate of the level of long COVID in the population. Because if you ask people on a survey who have had COVID, do you still have symptoms, many more are reporting than those estimates suggest. So that's where we're at the moment, and there is a lot of work that the CCG, working with our Humber Coast and Vale partners, are doing on that. And I might sort of point to Steph Porter as someone that could say a little bit more about that if there's any more to be said.
Thanks, Peter. I think you've gone through the main points. I just probably reiterate the question that went through my mind really early when we were talking about the long COVID clinics, and it links to the point that you made earlier on in the presentation. What about people who perhaps had COVID before testing was up and running and everybody? So that self-assessment of symptoms doesn't need an official diagnosis. So you can access services through that symptoms checker and the length of the symptoms have persisted. So we have a baseline of activity that we deliver, and we're just working on expanding that service with partners. So good response from Peter, with only a minor addition from myself.
Thank you very much. And I could see Charlie say thank you. Then Sally, I'm going to bring you in next in case it was to follow on, and then we've got Councillor Kilbane.
Thank you. Just one really quick additional point. So I suppose the access through to long COVID clinics is through primary care. So if someone's concerned, then they should contact their GP. And the reason for that is that many of the symptoms of long COVID can also mimic other things. So it's often necessary for primary care to do some initial investigations to make sure that it might be long COVID rather than something else, because it might require a different referral route.
Thank you for that, Sally. Pete.
Thanks, Chair, and thanks, Peter. Just a couple of questions, really. One, I was wondering how big a problem do you think underreporting is, given anecdotally, COVID seems to be absolutely everywhere at the moment. So, and of course, people are also taking the app off their phones. So how big a problem that is. And then sort of related to that, I guess what we do know is hospitalizations and deaths are our most accurate figures. And how does the current rate of hospitalizations and deaths compare to the annual rate for hospitalization and deaths for seasonal flu?
Thanks, Councillor Kilbane. I can try and answer bits of that, though figures may not be sort of absolutely on the tip of my fingers. However, underreporting has always been an issue, and I guess a disease which spreads asymptomatically and then also spreads because those who are symptomatic aren't able or don't isolate within enough time to stop it spreading to another person, I guess has been, driving infection across the pandemic. And it is something we're concerned about, that people are not going to get tested, particularly are not going to use a PCR test to get tested, but will use a lateral flow test if they have some symptoms as a sort of a fail-safe. Well, I'll just use LFD, and if it's not positive on that, it's probably just another bug. I would encourage people, if they have one of the 3 symptoms listed on the NHS website, but to be frank, if they have severe or even mild symptoms alongside that, such as a headache or muscle pain or fatigue, that if in doubt, getting a PCR test, there is capacity at the moment for you to be able to do that, and it is a useful way of us controlling this pandemic is to try and get people isolated when they test positive. But I do worry about underreporting. I'm sure it does happen. I'm not entirely sure what the effect has been of recent sort of restriction liftings, and it's hard to judge. Our testing figures at our PCR sites have been going up, but that's because there is more COVID going on, and people reporting symptoms on the King's College London Zoe app is another indicator we keep track of, and that has broadly gone up in line with recent trends of more COVID, but it hasn't gone up so disproportionately. For instance, it's not above the January figure that we think there's a large chunk of people missing from testing figures, if I'd say. I'm sorry, you're going to have to remind me, Councillor Kilbane, second part of the question.
Sure. Just in terms of the hospitalisations and death rates, how do the current rates compare to that we would normally have for seasonal flu?
So we certainly, in terms of excess deaths, are at the moment in York below the summer level of mortality. Not hugely, but as the slide showed, we've generally had rates over the last few months where fewer people have died than would have been expected during a summer, and so seasonal flu generally is leading to more mortality during the winter, and we're a lot lower than we would be in the winter. I would definitely say that hospitalizations currently, from what I'm hearing, and I'm sure other colleagues on the call would know more than me, all local regional hospitals, in fact nationally, we're seeing a large number of both that accident and emergency presentation and attendance, but also admission due to a number of factors, not just respiratory illness, but certainly a large amount of respiratory illness that isn't COVID, alongside that 20 to 30 number of people in a bed with COVID, and COVID still requiring quite a lot from our hospitals in terms of isolation and the PPE use, the social distancing, the measures that need to be in place to try and stop infections spreading within a hospital setting, which can be particularly nasty and particularly dangerous. It takes a lot of work within a hospital setting to make sure that doesn't happen, meaning that capacity and pressure is, from what I'm hearing, at a very high level for a summer. But Lucy, obviously on the call from the hospital, would be able to say a bit more about that. But we're not necessarily hearing of a high levels of influenza. That I'm pretty sure we're not seeing at the moment higher levels of influenza. Respiratory syncytial virus is the more the RSV is more what we're hearing, and from that we're definitely at a bit of a peak in our region. In other regions such as the Northwest, RSV has peaked and has gone down, but Yorkshire and Humber RSV has been steadily climbing for the last month or two.
Thank you very much for that. Just to check, Lucy, if you wanted to add anything. I
think we'll cover it in the agenda item 5, Chair, but absolutely what Peter's saying, we are still seeing COVID admissions, but also we're seeing admissions increasing for other non-COVID things at the same time. Great,
thank you very much. I can't see any other questions at this stage, so thank everybody for those questions and your responses and that presentation, Peter. And then I think, as others have said, we'll continue to touch on some of the items in the next 2 presentation. So agenda item 4 is from Steph on the booster and seasonal flu vaccination programs. And straight over to you, Steph.
Thank you very much. So hopefully people have read the paper. I've got some update on figures because obviously we submitted that paper at a point in time, but primary care and our community pharmacists always are the delivery focal point for the seasonal flu vaccines. That's planning in earnest, always tempered by the supply of the vaccine. So that's coming through now. And as I'll speak about the COVID vaccines, we call people forward for their flu vaccine based on ages or their susceptibility. So that programme will commence very shortly. Now, there's been a lot of conversations and discussions, particularly within primary care, around how we plan, administer, and just generally manage the workload around delivering both a flu vaccination programme, the first and second dose COVID vaccination programme, and then any booster programme, which would see a third COVID vaccine offered in those age ranges in the way in which we saw from December 2019. Just to remind people that we've been vaccinating since the last week in December 2019 for COVID, and that hasn't stopped. So when we talk about additional workload from our health professions, it's just a reminder that we've been vaccinating throughout that period of time. So we will start to see a more and more complex vaccination programme with flu and the first and second doses and the third doses through autumn and into the new year. But if I just focus on first and second doses, and just again link it to some of the data in Peter's presentation, York and the wards of York, they're at around about 82% first dose vaccines for COVID, and you've heard me speak about because we were vaccinating people in age cohorts, the significant number in York of 20 to 24-year-olds means that they came a bit lower down in the priority list, which was early to late June, those age ranges, but they are coming forward. It has slowed down across those age range, but we continue to offer those services, and together with our colleagues in higher education and further education, we're doing a number of pop-up clinics and targeted services. So students returning year 2, year 3, again, we'll continue to offer them first doses if they return and they haven't been vaccinated, as well as international students. So Nimbus are working with university colleagues to offer something on site. We haven't quite reached the point in like an airport lounge where you only get to sign on to your societies if you walk through the COVID vaccination lounge, but it has been a point of discussion. So those numbers are slowly edging up. Thank you to council colleagues who got us over the line with supporting a vaccination service on Parliament Street, which will be a walk-in service. I'm going to say the 28th is the 28th Saturday. So as I say, we continue to offer those pop-up services. many of our booked appointments this weekend past, we had quite a high rate of people not coming to a booked appointment for vaccines, but actually that was balanced out with walk-ins as well. The combination of other things to do and or poor weather influences vaccine take up. So we're slowly working through those numbers. Just coming back to some of the issues that we have in our primary care workforce, and I know Lucy will pick it up when she talks about the hospital, but just a reminder about primary care and the activity that takes place in primary care. 90% of access to health services is via your practice. And we are experiencing periodic high levels of sickness with both COVID and non-COVID related activity. Again, just asking and running our campaign, asking our citizens to be respectful. It's not an unlimited supply of primary care services, and our staff are doing their best to meet urgent care, and that often has an impact on routine care as well. So thank you very much for just being understanding around accessing primary care services. And I think I'll probably close it at that, just to update that we're around about the 150,000 vaccines now delivered, first dose vaccines for York citizens. So yeah, as I say, that's at the sort of 82% mark for eligible cohorts, and we await further instructions about additional eligibility criteria for the COVID vaccines.
Thank you very much. Thanks, Steph, for that presentation, and I'll open it for any questions or comments from board members. And I know we also have a scheduled update on the booster programme in September if we need it for our next meeting. So I'll just give a couple of seconds in case there are. If not, to obviously thank you as well, Steph, and to pass that on to colleagues for, as you say, an ongoing programme over a very sustained period of time, which I'm sure we all acknowledge. Charlie.
Thank you, Keith. Thank you, Steph. Just a couple of comments on university settings. We are now beginning to gather data from our new and our returning students. I got quite a bit in, not enough for me to proclaim any numbers to you. But we are not seeing vaccine hesitancy. We are seeing rates of vaccination which appear to be significantly above the age group. And we've got to bear in mind that most of these will have been done somewhere else and not in York. So that's a pretty promising situation. We're also getting some insight from our international students. And there's a note in the paper which suggests there has been low uptake across the Chinese student community. We don't think that's the case. We think that's probably an artifact of Chinese students leaving and not deregistering. The incoming student and the returning student numbers suggest that we don't have a problem of hesitancy there either. These numbers will firm up in the next few weeks, but they are looking quite promising, and I checked with York St John as well, and they've got a similar situation.
That's great news. Thank you for that. I agree with you about the artifact of the numbers. We think we may have a variation in our reported data via the system called NIMS of around about 4,000 young people. And we're just trying to understand if that is students who are now out of country, but they still linger as registered patients. So some of the reasons why our 82% is at that rate is because we have what are not unsubstantial numbers that as you say, are artifacts. And I agree about the hesitancy. One of the things that we want to do is to make sure that we link up and we do a train the trainer event around making sure that when we're running the pop-ups for specific groups, that we do have people on hand who can have a more detailed, richer conversation, and as you say, just sort of really heartened to make sure that we make access as easy as possible and that the offer remains as such. Just if people will indulge me, there's quite a big piece of work that makes the admin quite complex around understanding about when somebody's had a vaccine that is out of country. There's something about making sure that our recording systems are drawing through. Even other nations of Wales, Scotland, Northern Ireland, the general practice systems don't link up, so we've got a bit of work around that. But also our health practitioners got quite a detailed piece of work to do around matching the most like vaccine that's out of country and then in country, particularly if students arrive and they've just had the first dose. So we're on with that and working really well in partnership. So thank you for that.
Thank you for that question and the response. So if we note, obviously all of that information and the update and the fact as mentioned that we might well return to that in September, that then takes us through to agenda item 5, which is a more general point on the easing of restrictions and the impact that this has had locally. And this is what we specifically asked for at the next meeting, and particularly to come together at this time to look at that impact. And I'd like to thank a number of colleagues who have contributed to the report, partners, different officers in the council. And I know that Peter is going to do an initial introduction, but I'm sure those that are on the board that have contributed will want to talk to their slides as well. Peter.
Thanks very much, Chair. And yes, as you say, I'm just going to act as a bit of an intro and host to move this through, really, but particularly for some of the things that we're discussing here, it'd be really good to go to board members directly to cover their items. And I'm looking down at the different sort of chapters of this presentation, as it were, the different areas that we're looking at in terms of local impact, and seeing these first 3 as areas that I might just briefly cover, but obviously others are able to give their views, and the 4, 5, 6, and 7 I might hand directly over to board members, if that's okay with you, Chair, to take through. So I wondered if, thinking sort of rather off the top of my head, really, if we took 1, 2, and 3 together, I think it's 4 slides, and if I just cover the data that's in them and then we open out together, does that work, Chair, in terms of a way of running through this?
That's great. Thank you.
Okay, so we've asked some council officers and partners to just give us some headlines on some impact. And this first slide, coming from Simon Brereton, our Head of Economic Development at City York Council, just with some economic headlines, and there will be much more detail underneath lots of this. Obviously, pandemics have huge impact both on economy and jobs in the labour market. So Simon is noting that unemployment is now falling, but there are still 2,000 more out of work benefit claimants than pre-pandemic. And the next slide that comes shows that on a graph that peaked and has fallen, but as Simon is saying there, we're still at a scale above where we were going into this pandemic at historically low unemployment levels. Many businesses facing challenges in recruitment, particularly skilled and semi-skilled roles, and thinking of York's particular employment mix there too. Board members might wish to comment a little bit on what they would see the challenges would be unique to York, because obviously lots of commentary on the economy and the impact of COVID nationally, but we know that York as a city has characteristics in its workforce and its jobs and businesses that we probably like to reflect on. Many offices remaining in remote working mode, and only 40% we estimate of businesses are currently in the pre-pandemic place of work. Now, obviously, that doesn't mean only 40% of people are actively going to work as opposed to staying at home, because many businesses throughout the pandemic have been having to staff for face-to-face customer contact, etc. But certainly that will mean our city centre during the working week and our offices and businesses are quieter as companies take that return to work slowly. Simon also noting our economic recovery, which is being driven by tourism, with 2 out of 3 visitors we're finding out from outside of York when we look at surveying those who are out and about doing their shopping and on the streets. The next slide, if that's okay, Richard, just shows that actually benchmarking against other cities, and this is a Centre for Cities report, the High Street Recovery Index, really recent data, that actually the story is very good for York in terms of footfall and spend. So actually we're 5th in the country out of 68 of the biggest cities in the UK for footfall, and 3rd for spend in terms of city centre recovery. So I think that's something to really celebrate, something to build upon in terms of the jobs, the businesses and the income that represents. Obviously presenting us challenges as a compact city, which needs to make sure that our city centre is a COVID safe place to be, and a mountain of work has been led by our public protection and economic development colleagues and city centre teams to try and make sure that York is as safe for those coming in, and I would say from a public health perspective as well, access to testing, lateral flow testing is available for visitors and residents of the city centre through the St William's College testing site. Next slide if we could. So I think this is the slide which shows us our unemployment figures stretching all the way back to 1986, and it feels as if we've covered this, but that's there for comment if board members would like to. Next slide, if that's possible, I think takes us on to public protection and community safety. And the slides are taking just a little bit longer to load for me, but hopefully the next slide is what I'm expecting it to be. Matt Boxall, our head of public protection, has just summarised a few headlines here. Since businesses were reopening, first of all with outdoor service in April, and following the rule of 6, and from the 19th of July with most restrictions lifted. Reopening businesses have gone smoothly. I would add a public health point in there, just as a resident of York, that it feels like when you're out and about in York, people are being very sensible with mask wearing and wearing masks as and where they should be within enclosed public spaces. As the guidance says, it is still advised to wear a mask when a space would be indoors and enclosed and likely to contain a large number of people. And it feels anecdotally as if that is the case, and there is a lot of support for the council's key messages around being kind, respecting other people's approaches to that, and it feels as if the city is doing that. We've been promoting the Visit England Good to Go scheme, helping with those messages around opening safely, the city centre being a place which has got the required things in place to help with distance, ventilation, mask wearing, but also to help shops and businesses open. Reporting that the security industry is facing challenging times, and like many industries impacted by self-isolation rules, and still now with 30,000 cases per day in the UK, there'll be a number of people every day falling ill with COVID and isolating in the city, which does have impact on that face-to-face and customer-facing work most of all, and events that are slowly returning. And Matt is noting that many large events are not being arranged, concerns around increasing case rates in the last month, insurance being a particular issue, to flag as well that the council's safety advisory group is the body responsible for vetting large events, and does give views and opinions on large events that go ahead from a safety point of view, and so is actively involved in those processes. And I think the next couple of slides, if we could go on, cover our neighbourhood enforcement team and what they've been seeing. So I'll just wait for them to move through. Taking a bit of time for me. The problem when you haven't written a slide set, you don't actually really know what is coming next, apart from having read through them early on today. But hopefully these slides should change soon. So around community safety, we are seeing increased complaints of antisocial behaviour, young people gathering in open spaces, large groups. That is obviously there is a summer aspect to that is a well-known phenomenon. Antisocial behaviour is higher during summer months in the United Kingdom, has been seen for many years. Associated noise, litter and underage drinking. And just to assure partners that we have a community safety hub in York where police, neighbourhood enforcement and housing and other colleagues, health colleagues, actively are working with the problem-solving approach. And I'm sure sort of Lisa on the call and other colleagues will be able to speak to that in a sec. At the next slide, if we can, I think is the last one, again, just around some of the things that our neighbourhood enforcement team have been seeing. And once we've got through this next slide, I will stop. So high volume of calls for neighbourhood enforcement around noise and around litter. And Chair, we were going to go on to the next bits, but I will leave it up to you to see if you feel like we should take some questions at that point. Obviously, we've covered a lot around the city centre, the economy, so it feels perhaps quite a coherent place to pause and just reflect, but we can continue and go through if you'd like.
Thanks very much. I can see that James has indicated, so I'll bring James in now.
Yeah, thank you, Keith. Yeah, and just to back up what Peter was saying, really. So at the moment, business confidence is really high. So all the indicators are that the confidence we're reporting back is that people are pretty confident. And whilst unemployment is up on where it was pre-COVID, we know there's a lot of job vacancies. And actually economic forecasts are that job numbers will get back to pre-COVID levels later this year. So whereas previously we were forecasting that would be in 2023 or 2025, it's now forecast to be in this year. Now clearly the lack of overseas labour is impacting on the number of job vacancies and that are around at the moment, and that's both a bit of the EU exit and also partly COVID as well. I think the big question really that comes out of this is what is the quality and sustainability of the jobs? So we've obviously got quite a strong retail and tourism sector in York. We've got a staycation boom at the moment, and obviously people who are looking to stay in the UK, we're seeing that York is one of the most popular places to visit, which is demonstrated in the footfall and the kind of the spend patterns in the city centre. The question is that the jobs that are being created at the moment, how sustainable are they going to be going forwards when we move past that kind of staycation and get back to what might be kind of a normal traction from that perspective. And also there's a bit of work to be done if we've got the unemployment numbers up, matching the skills of those who are unemployed with the vacancies we've got at the moment, because we know that there remains a lot of vacancies out there that are very difficult to fill. yet we've got these stubborn employment numbers alongside it. So it's the matching of the skills is one of the big challenges, and the other is the concern around the sustainability of some of the jobs that are being created.
Thank you for that, James. What I think at that point, if we go back, Peter, to the slides, and I know, as you'd mentioned, we're going to bring different colleagues in the different sections. So I think it would be Amanda, if I could go to, and then we'll pick up any questions or points at the end as well.
Thanks, Chair. So I'll take you through children's and adults social care. So in children's, there is an increase in demand, but it's not massive, and it is less than a number of areas are seeing. We are, however, seeing a change in complexity. We are seeing children and families who haven't been known to services before coming forward for service. We are seeing an increase in people coming forward for early help, which is great because it means they're looking for support at an early stage, and that's been consistent through the pandemic. So, you know, if people are feeling that they need some support around parenting their children, then coming forward early before it gets to crisis point is great, because there are services that can support you. There's definitely been a rise in domestic abuse, and all those other complex safeguarding areas we're starting to see coming through. Next slide, please. But what we are particularly seeing is a rise in emotional health and wellbeing challenges for our young people, and have some particularly acute cases in the system at the moment, where we've got some young people who have very acute levels of distress, and anticipate that that's something that will continue. We have got some really good partnership working. We've had that right the way through the pandemic, and that's continuing to be in place. And working and finding kind of outside the box solutions for some of the young people who have got very complex needs, and having some success in supporting them young people as well. We've got some major workforce issues. Social work's a shortage service anyway, and there's been real challenges around recruiting experienced social workers for years. That's continuing to be a challenge across both adults and children's services, and the demand for increased numbers of staff, particularly in adult services, has meant that there is a real shortage of supply, including agency workers at the moment. So we're doing lots of work around how we can attract people to want to work in York, and looking at our terms and conditions around particularly experienced social workers, so we can make sure we can attract enough experienced staff to meet demand. Next one. Adult social care is in a difficult place, and that's particularly because, as you've heard in previous meetings, all of the system is under significant pressure at the same time. So for those that don't know what OPAL levels are, and there is no real reason why you should do if you don't work in this world, they're around escalation levels, so around how able are we to meet demand. So the whole system, adult social care and the health system, has been reporting OPAL 3 and 4 for over a period of time. And that's particularly because just of the volume of need in the system, and that's exacerbated by, as you've just heard, some of the workforce challenges, which are particularly around getting staff to work in provider services, so domiciliary care and residential services. It's not a York issue, it's not a regional issue, it's a national issue, and we are doing some work as directors of adult services across the region to identify what this is about. But some of it is because those other shortage occupations, i.e. hospitality, have improved significantly their terms and conditions, which means therefore that domiciliary care is a less attractive option in terms of the amount of money that you get paid. So that's creating some real challenges, which means that people can't necessarily get the packages of support that they need to come out of hospital, which means therefore that there's delays in terms of people being in hospital, etc., etc. The context for adult services continues to be challenging. Mental health services are very busy as well. And again, we're seeing people coming to the attention of mental health services who haven't been involved with services before. So again, if you if anybody who is watching this is feeling unwell, is concerned about anybody's mental well-being, then please do access services sooner rather than later. It's really important that people access the support as early as they possibly can do. Next slide. So we're into winter planning, and solidly into winter planning now. Although some of the colleagues on the call may well say that it does feel like winter has come in August, and that's not just because we've had a change in the weather, it's because we're very busy. Some of that is around trying to look at recruitment pathways and what we can do to support our provider colleagues to make sure they've got sufficient staff to deliver the support that we need. So we're looking again regionally and sub-regionally at what we can do around attracting people into that market and attracting people into care as a career, not just as a job. You know, some of you will have heard me say this before, but my first job was as a home care assistant, and look where I am now. So, you know, it's a fabulous job to have. So really looking at how we can support people into that. Doing a lot of work as well around workforce resilience. It's been really difficult to work in frontline services throughout the pandemic, and, you know, everybody on the calls experienced that. So doing some emotional support for staff around giving them an opportunity to talk about what they've been through so that they're strong enough to go into the next wave. As Peter said before, we are seeing the impact of COVID rates increasing, but it is also about other health conditions and other wellbeing conditions that are making the entire system busy. So it isn't just about the COVID numbers, it is things like RSV, it is things like other respiratory illnesses that we're seeing people go to hospitals with. That's it from me.
Thank you very much for that, Amanda. And I know that we can now go on to Lucy.
Thank you. So this is an update regarding the hospital, and following a period of, although perhaps it maybe didn't feel like it at the time, following a period of respite, I suppose, where we had lower numbers of COVID admissions than we'd seen since the start of the pandemic, and at points we were not seeing any COVID admissions at all. This has started to increase again, and since the end of June, we've had a further 169 COVID positive admissions into our hospitals, and sadly we've had a further 20 deaths of patients with COVID-19. So we've continued to operate within our COVID world, if you like, and these figures are about a week and a bit old now. So actually we've now got about 50 patients across our hospitals. So that's predominantly the York and Scarborough hospitals of patients with COVID-19. And this is in comparison with the peak back in January 2021, where we had 216 patients. So the numbers are not approaching anything like what we'd seen at the worst of the pandemic. However, we are continuing to see admissions at a sort of fairly steady rate. And we are running with 2 COVID positive wards at York Hospital and 1 at Scarborough Hospital. And even though these numbers are much lower than we saw back in the start of the year, our hospital services are remaining under significant pressure, and there are a number of factors behind that. If I could have the next slide, please. So the key factors, and we've touched on some of this already in other colleagues' slides and also in our earlier discussions, but we are seeing really high numbers through our emergency departments at both of our hospital sites at the moment. We've seen a significant rise in attendances, and this is not the sort of activity we'd expect to be seeing at this kind of time of year. It really does, as Amanda just said, feel a little bit like winter in summer, which is obviously causing a little bit of concern in terms of planning ahead for winter and what that might actually bring for us. Again, as Amanda and Steph talked about earlier, we've got some really quite pressing workforce challenges. We've got staff who are off sick. We've got staff having to isolate due to test and trace. We've got some long-standing vacancies and recruitment challenges across certain specialties, which existed before the pandemic, but certainly haven't resolved during the pandemic, and those continue to be the case. And as others have talked about, that's not unique to people working in acute hospital services. That's throughout health and social care across the country, but it's certainly taking its toll in terms of the pressures that we're facing. And we're also finding that as staff have been working under the pressures of the pandemic now for such a prolonged period of time, that we're seeing lower uptake for bank and agency shifts, and staff are fatigued, and we are seeing the impact of that, and it's entirely understandable given the past 18 months. Unlike back in March when the pandemic first started, and we were required to postpone lots of the work that we were doing, the routine work that we were doing, and just focus on our COVID response, and also continuing with our most acute work and our cancer work. Throughout the past few months, we've been continuing to do as much of our routine non-COVID work as we possibly can. And that's been difficult to do because we can't just simply operate at the levels we operated at before. There are still requirements around social distancing, infection prevention, how you run services as a result of the risks of COVID. So we are trying to recover what is now a significant backlog as a result of the pandemic, whilst also still, as we talked about, managing the steady numbers of COVID positive patients as well, and trying to get that balance right is quite a challenge with the restrictions we have in terms of the state, in terms of staffing and resource. But we are working really hard to try and recover as much of that backlog as we can, and we have made some inroads into some of our longest waiters, which is progress, but that's not to underplay the significant amount of work we still have to do to address that backlog that we've got. I think that was my last slide. That's all I want to say, unless there's any questions at the end. Thank you.
Thank you very much for that, Lucy. And then if I could hand over to Alison, please.
Hi, so I'll add to the gloomy picture. So I have been predicting charity closures due to a whole range of issues. We've started to see that happening as we've had 2 closures in the past month, and one hanging on by the fingertips, and that's due to some of the reasons on the slide. So a lot of charities generate income. We trade in order to make ends meet, and we've had 87% of organisations had a decrease in earned income. Obviously, we couldn't trade last year, and we haven't been able to make that up, and it's still very tough out there. We are seeing reduced paid staff and reduced volunteers, along with an increase in demand in complex services. As Amanda said, it's the same in the sector as well. Real complex cases needing a lot more time, but we've got fewer staff. The worrying thing for me is about reserves. So a third of organisations have used their reserves, and some have used practically all of them. And once you start using reserves in a charity, it is a slippery slope, because once they have gone, you are gone. And that's what we're seeing happening now, is people have been using reserves in order to subsidise themselves when they're not trading, and obviously those reserves will be running out. Digital exclusion is an issue for all of us, so that's just sort of down there. So I think, just to sum up, at a time when the sector is needed more than ever because of pressures within health and social care, we are struggling. We have the same workforce issues, in that we can't recruit staff. There's very few people out there, so we are constantly recruiting, but it's getting tougher. And because we have lots of very short-term contracts, it makes it almost impossible to recruit now. So it just continues. Similar challenges, I think, across the system by the looks of it. That's it, Keith.
Thank you very much for that, Alison, and to everybody for their work inputting into the presentation and the pack that I know went out with the agenda. Just to open it now in case there are any questions or comments. Pete.
Thanks, Chair. A question for Amanda, really, because obviously Opal 4 is about as bad as it gets, emergency acute safeguarding only type situation, very dire situation indeed. I guess my sort of multi-million-dollar pound question is, given that we've already used quite a lot of the COVID grants to maintain adult social care, and those grants are stopping, if the situation stays as it is without extra funds being injected into the local authorities, will we be able to provide our statutory services in children's and adult social care and balance the budget, or would providing them make us overspend so much we essentially go bust?
One of the main grants that's in place at the moment is the Discharge to Assess grant. So that's in essence money that's provided to support people to transition out of hospital and be assessed whilst they're in that transition phase. That grant is due to end, and there is a lot of work going on nationally at the moment with the Association of Directors around the challenges of if that grant were to end. It gives us a significant financial challenge, but for larger authorities, it's a massive financial difficulty. So that's the main one, and there is work being done, as I say, around kind of lobbying for that one. On the OPAL issue, one of the reasons that people move the OPAL levels is because that then generates mutual aid across the system. One of the things that isn't happening at the moment is that the system isn't able to provide mutual aid because it isn't one bit of the system that's under pressure, it's the whole system at the same time that's under pressure. So almost the OPAL levels cease to have meaning anymore, because there is no point declaring a higher OPAL level, because it doesn't mean that you can get mutual aid from any other part of the system. What's important is that we work and plan together as a system around how we can prevent people going into hospital, how we can support people to live well in the communities, and how we can support people to exit hospital well and retain their well-being, because those are the bits that are really, really important. And we've been doing lots of work around that, particularly around mental health, around prevention from admission into hospital and prevention from readmission, because those are the bits that are going to help people be as well as it's possible for them to be.
Thank you very much. I wonder, picking up that point, Amanda, we've done quite a lot of lobbying, I know, as an outbreak management board with public health and the Department of Health, whether we could pick up that example that you gave. I'm sure, as you say, the National Association and the LGA will be doing similarly, but if you could help us craft a note.
There is a paper that's been written regionally from all of the DASIs, which I've seen a kind of near to final version of today. And the idea behind that is that then we all use that to go through all of the different mechanisms and networks we can do to outline the situation for adult social care, but the impact that an adult social care system in difficulty is having on the rest of the system, particularly on the health system. So as soon as that's ready, I will get that to you.
That's great. Thank you very much. Sally.
Thank you. One quick reflection on the impact on primary care. Steph already touched on it slightly earlier. And then a quick question for Alison, if I may, about the voluntary sector. So I just, from a primary care perspective, I'd probably just echo what Lucy said around the workforce difficulties and the fatigue and the lack of ability of staff to step up and do extra shifts, which we have often relied on in absences in the past. And primary care has its own significant backlog of work as well, both in terms of chronic disease reviews that we would normally do on an annual basis, but also lots of things that people have saved up and not approached us about and are now starting to approach us with, whilst also, I suppose, trying to support lots of people who are on the hospital waiting lists, which we know while they're waiting, they'll still have symptoms, they'll still have concerns, so they'll approach us. So it's a similarly gloomy picture, really, in terms of the impact on workforce. And I think that's just a concern going into winter when it may get worse, and a concern around another significant vaccination programme, which is also going to take a significant amount of workforce. And we'll continue to work collaboratively together to do what we need to do to provide the essential services, but it's certainly challenging on the ground at the moment. And my quick question for Alison was just, in terms of voluntary sector struggles, is there any particular pattern in terms of the organisations that are struggling the most and the services that they have particularly provided? Just, I suppose I'm trying to understand if there is a particular demand for certain things that are not being provided elsewhere in the system, or is it just struggles across the board?
So the demand for the voluntary sector always will come when the statutory sector is peaking, you know. So when people are on waiting lists for for health and social care, they will come to us. I mean, mental health is absolutely on the increase with massive demands, and it's just as the system pressures overflow, they come to us because we are the last port of call, basically, a bit like A&E in some ways. There's no great pattern, I don't think, across the board. I think any weaknesses that were within charities are just been exacerbated because of COVID. So, you know, if you already had some challenges, you know, perhaps with governance or whatever, they will have been, you know, exploited through COVID because it's a weakness there. So no great pattern. It's quite complex, to be honest, to sort of try and explain it. That answers your question, Sally, sort of.
Yes,
Thank
thank
you
you.
very much. Sian.
I sort of have three things I wanted to say, observe, question. One was, given the system pressures that we know exist, and given the challenges people are having using the system at the moment, do we feel that those most able to navigate the system will get the best results? And so is the deepening of health inequalities inevitable? And if that is the case, what can we do to prevent that? I guess as well, something that's been coming through a lot of the meetings I'm having with people, through things like the Mental Health Co-Production Network, through things like the Multiple Complex Needs Network, is concern about the workforce working in care. And again, sort of echoing the stuff around system pressures, the question keeps coming up, who's caring for the care workforce? People are really worried about this. And there was a question for me around, do we know what the gold standard of support would look like for our workforce? Do we know what we should be offering them? And are we doing that? And is there anything we could collectively do to improve that offer or to better understand where we're not giving them everything they would like? And my third bit would be for Alison around the reserves issue and the capacity issue within the voluntary and community sector. And if we within the voluntary and community sector are going to be a vital part of the ongoing transformation of the system, post-COVID, through things like the integrated care system, are we actually in a position to play that role given the pressures and challenges within the voluntary sector at the moment? Do we have the capacity to be where we need to be to help take forward the system challenges in our current state? So I suppose those are my questions / comments.
Yeah, thank you very much. I'll bring Amanda in first, and then I thought, Peter, whether you wanted to pick up the first question, and there was also for Alison, but if anybody else wants to come in, please indicate. Amanda.
Yeah, in terms of workforce, I think, yeah, people are right to be worried about the workforce. You know, they are, as everybody said, they are tired. It's been really difficult. And it continues, you know, so we do absolutely have to do everything we can to support the workforce. We are lucky in York, though, because we've got access to the resilience hubs through our mental health colleagues, and we've been working with them to look at sessions for our staff, and also to look at sessions that go across agency groups. And we've also done some work, Lisa might want to comment, with our police colleagues around trauma and recognising the impact of trauma, and they've gone down really, really well, and we've done those in multi-agency groups. So, you know, it is well recognised, well researched services that we're putting in place, but it does continue and will continue to be difficult to work in these fields over the next period of time because of what everybody's dealing with and how tired everybody is.
Peter.
Thanks. I mean, I'll just reflect on that health inequality question you raised, Sian, and I'm afraid I don't have any solutions, but I would probably answer your question to say that yes, we already know that COVID has affected society and population health unequally, and we've had a decade in which inequality has risen. If you just look at the bare indicators of life expectancy and healthy life expectancy, the gap is higher in 2021 than it was in 2010. Michael Marmot talked about the last decade as a lost decade in those terms, and we can expect that won't have got better due to COVID and is likely to have got far worse. So I think it's ever more taking an inequalities, and particularly thinking about the the health and the well-being of minority populations and those most likely to be left behind. That has to be hardwired into the work that we are doing from a strategic perspective, and we've got to make sure that isn't just sort of tokenistic, but is something that we look at in all policies that we do, that we know that generally the healthier you are, often the better healthcare that you get, because you're more able to advocate and search out the best quality healthcare. So how do we make it as accessible as possible? How do we look to communities that may struggle to access it? I think we're all doing that, and we're all probably trying as hard as we can, but that can't be something that we let go because of the system pressures. It has to be something we keep on doing, and as public health, I guess our commitment is to try and work with partners to enable that to happen as best we can, but also to keep a very close eye on what the data is telling us about our population and how health is changing and how inequality is affecting populations, and as and where that is changing, because there are some areas of health in the last 10 to 20 years where inequality has actually got better, and there's some areas where it has got worse, and in that sense, I think understanding where we best focus on is something that we will help us prioritize, and certainly through the work the ICS is doing at the moment, the healthcare system is changing. Again, we need to keep that front and center and make sure things are not just about structures, but are about people and population need.
Thank you very much. Alison.
Thanks, Sean. So I don't think the VCS has any choice but to be involved in the system-wide challenges and making sure we play a part in that. Ideally, we'd be involved from the beginning, so that we are part of any new pathways that are developed, and so the sector is paid in that sense. So if we get involved in a pathway, the part we play is reimbursed, which will help strengthen the sector. So that's what we're aiming with around co-production, is making sure that we're in there. I mean, clearly we have to get involved in lots of discussions, and we squeeze them in, as you know, we don't have capacity. We squeeze it in. In some places we do get some expenses for our contribution, but that's certainly not across the sector. And something at York CVS we try to do is look at where we can reimburse, especially some of the smaller groups, their involvement in us accessing their customers in order to understand their experiences and so forth. So it's something that we should be looking at more across the system, is that if we want to involve voluntary sector groups in stuff, we need to be enabling them to do so by rewarding them or just reimbursing their expenses. So just to say on the stuff I talked about before, we are looking at working with the sector to come up with some recommendations. So from the situation we're in now, I don't want to just pick them out of thin air myself. So we're going to have a session in September and look at what does the sector want, what help do we need from the system, so we can hopefully change things for the better.
Thank you very much. Lisa.
Thank you, Chair. And it's just to echo some of the points that have already been made about the systems approach. So it is putting pressure on the whole system, really value the neighbourhood policing and partnership working across agencies out there in the community. But I think we're all experiencing a lot of demand and are trying to react to the immediate demand for obvious reasons. And I suppose my plea is that not losing sight of the prevention, getting upstream of the harm, because actually I think that there is further demand coming across the system. We're just starting to see some of those resilience issues hitting communities where a lot of our calls for service are in respect of people's well-being, concern for safety, suicide, mental health, people in desperation. I think as people start to move through perhaps the end of furlough, and we will see the effects of that, we'll have additional pressures on people and their well-being that will hit again the whole sector. So it's difficult to try and continue to put that investment into prevention, early intervention and upstream of the harm, when actually, and Amanda talks about Opal 4, there are people struggling just to deliver the demands of today. But I think as a system, we have to not lose sight of those demands of tomorrow as well, in close partnership working. So I really welcome, Alison, you saying about getting in there early, because some of those voluntary services are absolutely essential to supporting that systems approach. I also think there are thousands, hundreds of thousands more people on holiday in this country who wouldn't ordinarily be. And that also puts pressure on the system, because those people are moving around and accessing our services that perhaps wouldn't be in those numbers, and particularly in the City of York, when we know every available space, which is great for the economy, every available space is taken up in terms of accommodation and hospitality. And that's great for the economy, but again, puts pressure on the system. So just a real need for us to continue to work on that prevention and upstream harm reduction whilst we try and deal with and support that immediate demand.
Thank you very much for that. What we're doing today is obviously noting the impact and that conversation that we've just had. What the suggestion is we bear in mind any of those particular areas that we'd like to come back in the future. So one of our later agenda items is to obviously look at the forward plan and future topics. So bear that in mind. And obviously, if there are particular topics that you'd like more detail on, we can schedule that in for future meetings to make sure that we keep focus on those areas. So thank you very much for all of that. That then takes us to agenda item 6, which is the communications item. And Claire is back with us, stepping in for the team to present this. Claire.
Thank you, and thank you to the group and the board for everything you've just shared. Obviously, there's some really difficult conditions out in the health and community at the moment, and some really incredible pressures that everyone's experiencing. And just before I got onto my communication slot, I wondered if it would be helpful just to add just to think about future meetings, which we can come on to the end, whether you would find it helpful for us to talk about the communications response to some of those pressures from the council. So we're working, for example, closely with the CCG and regionally and taking a local flavour on how we might be able to manage some of the pressures in terms of essentially diverting non-essential care, if you like, to other sources of information rather than putting more pressure on the system. So sort of a demand management approach. We're looking at how we can make York a really encouraging and beautiful place to work, because actually we've got problems around recruitment that I think lots of us are experiencing in different sectors, but certainly within social work, social care, and also the business support teams that support social work and social care. We're having tremendous problems identifying and finding people. So we want to make a solution there, which actually might help other members of the board as well, if we demonstrate what a great place York is in to work in. And then working very closely with Peter on how we can support health inequalities through the work with the integrated care system. So just before I got on to what feels really quite light and fluffy now, if I'm honest, I just wanted to sort of just make the point about we are doing what we can to support the pressures, and very happy to talk to this board about it next month or in future sessions. So that's my little bit before I got on to the recovery communications. Richard, are you okay to stick up the first slide? Thank you. Oops, right. So you won't have seen all of these before, although you might have seen them around York, of course. We changed, as you know, the key messages that we wanted to communicate to our visitors, residents, and everyone that sort of comes into the city, commuters, etc. Mostly taken on board the advice from the Behavioural Insight team from Public Health England, which you'll remember we worked with over the last few months, being very, very super clear about what it is we want people to do. But at the same time, very much taken on board the advice from our business sector and the Tourist Advisory Board, who, it was mentioned earlier, are experiencing some hostility from people who are visiting their services, to make it clear that in this city, we protect each other, we respect each other, and we're kind to each other. Next slide, please. Oh, it's slow, isn't it? So same phases. We're on phase 4. We're in the recovery phase. We're very ready to get ready for any kind of spike if we need to. But right now we're in phase 4, which is encouraging, actually. So moving on. That just gives you an idea of the different approaches that we employ, as you remember, through the different phases and the different times. The tier system feels like a long time ago now, but at the time, as you know, it was quite tricky to manage. Moving on, please.
This just goes to show you the sort of latter part of 2021, so from June to December. And we're very much in the Let's Be York campaign phase, the vaccination, supporting vaccinations, supporting Feel Real York, which is our response and how we're supporting some of the emerging mental health pressures that are being experienced. And then also What's My Next Step, which is around helping people know what to do next. If we'd like to move on, please. Oh, it's slowed. Oh, here we go. And again. Again, we'll go through the normal format of the communications update, and I'll whiz through it because I know time's tight, and actually the conversation we've just had is the really important one. This conversation is just to give you an update. As always, lots of press releases going out. They're about 50% COVID and about roughly 50% media inquiries about COVID. So it has reduced quite significantly over where we were at the start of the year. Moving on, please. Again, we're continuing with our regular rhythm. Again, we're creeping up on our resident e-newsletter and our business and families e-newsletter. And you continue to receive, of course, the weekly email update that we send out. Also this month, we've had a Facebook Live taking place last week, which was really to help people with some of the kind of strangeness, if you like, around the self-isolation rules. If we go on, please. Again, thank you. So just to let you know things that are going on, taken on board advice from the board last month, we issued a joint statement from our political leaders as we moved into step 4. Our city's hitting your doorsteps right now, so you'll be getting all sorts of information, including how to get tested and some myth busting around the vaccination programme. Moving on, please. Ooh, there we go. We worked really closely through the head of communications group to develop a partnership campaign, and thank you to many of your comms leads who took part in that. This is the approach we're taking. It's to clearly show both the behaviours and the actions that we want people to take, and you'll see these all over the place. We've got them in obviously on our channels, social media. We've shared them with partners who we're very grateful are sharing themselves, and we've got them sort of displayed across the city centre on bollards and posters, etc. Moving on, please. It's just another example. We've got these freely available to download from our website, and we've seen that people are using them, so that's great as well. And you can see there's a kind of different selection that people can use for different circumstances. Thank you. Moving on, please. They're at the vaccination site as well, which is helpful. These are just examples of where you could see them. So there's Healthwatch sharing the information. There's an example of one of the bollards, posters in people's windows and posters on lampposts. Thank you. Moving on, please. Testing. So we're continuing to support the testing programme, making sure everybody's aware of where you can get free tests, which are all over the place now, which is great. Information in our city, the resident update through door-to-door information, and then direct comms to residents every week. We've also this week issued a letter to schools, which if you've got school children, and I have, you'll have got a letter from Sharon Stoltz, the Director of Public Health, which shares where to get tests from for the start of school for when pupils return to school. Moving on, please. Vaccinations, continue to support the vaccination programme. Lots of information in our city, which is myth busting, really to tackle some of that anti-vax nonsense that's around, but also sharing information on Facebook Live, resident newsletter, partner communications, and at the vaccination sites itself. That black square in the middle of your screen is actually information that's on the car parking signs. So they're dotted about the city, telling people about traffic flow, and we're making sure that people get to hear information on that as well. Moving on, please. And then self-isolation, this is the last slide, I believe, and this is just to say that as we moved into step 4, and there were some challenges around communicating the self-isolation rules. As you know, it was different. It was kind of a bit more, it was less required and more guidance. So we provided a Facebook Live session to help answer some of those questions, shared that across our business bulletin and our resident newsletters, and shared it with partners as well. And then I think that's it, if you'd like to come out. Oh, what final one? Sorry, apologies. Of course, this is COVID related in the sense that it's to do with helping people stay fit and active following essentially months and months inside. So we're continuing with the deconditioning. I hate that word, by the way, but the deconditioning campaign to encourage people to take up physical health and just take simple steps to get moving and to get their bodies working again, and to get stronger and more healthier as we sort of move back into normal life. So that's it. Thank you. Thank you very much. Over to you.
Thank you for that, Claire. Open it for any questions or comments from colleagues. Pete.
Thanks, Chair. Just a quick comment, Claire. Thanks for that. I've talked to quite a lot of 16 and 17-year-olds, obviously been a sort of a target group to get vaccinated, and they either didn't know whether or not they could be vaccinated, or if they could, how they went about it, whether it needed to go through the GP, etc., or if they were getting vaccinated, then where to go and do it. And when I tried to look up online to find out that information, it was complicated and difficult. And actually, the best source of information with York was York Mix interviews. And you know, all due respect to York Mix, I don't think it's the #1 go-to for 16 and 17-year-olds. So I think everybody here needs to think about how we communicate with that group, because as far as I can tell, the message isn't getting through clearly, and that might be getting shown in the stats.
That's a really good point. Thank you, Councillor. Interestingly, we spoke to the NHS Improvement Board on Friday about just the same problem, and about how they can, how we can work together to put in place essentially tools and assets that we can share with 16 to 17-year-olds and the channels that they use. So that's definitely something we're working on. We can bring that back to our next session. We're working with Nimbus Care, of course, as well on that. So that's a kind of joint activity. Thank you. Do you want to actually add that to the list of next month as well?
Yeah, very happy. I don't know whether Steph, this I could see nodding with your suggestion. So perhaps that is one for a future item.
Yeah, it's always a moment, a life full stop when you're told that you're not the right person to give a message to a target audience. So yes, we are looking for more appropriate influencers. So yes, it's definitely on our radar.
Yeah, that's the conversation we were having around which are the best Instagram and TikTok influencers that actually 16 to 17-year-olds would
like a foreign language.
Certainly not me.
Yeah.
Yeah.
Great, thank you very much. So we'll note the rest of the communications update. That takes us through to agenda item 7. Which we referenced earlier. So if any board member has any suggestions for other agenda items that we haven't talked about today, please just get in touch outside of the meeting, and we'll add those to the standing items and items that we've already agreed in the last couple of board meetings. And then agenda 8 is to consider dates of future meetings. The suggestion that you might want to consider is, now that we're in stage 4 of the roadmap, after our September meeting, do we then change to a every 2-month pattern? Obviously, nothing to stop us adding an extra meeting or reconsidering that in the future. If you were happy with that arrangement, that the dates that Democratic Services have suggested are that the next meeting would stay as the 29th of September. We would then follow with the 24th of November, the 26th of January, the 23rd of March, and the 25th of May. I'll just give a couple of seconds in case anybody wants to make a comment about that. If not, I'll take that you're happy with that suggestion, and obviously we can then review it at that September and November meeting if it doesn't feel right at the time. So thank you all for that. The final agenda item is any other business. I'm not aware of any. So again, hopefully nobody is waving madly at their screens to suggest it. The Wi-Fi here in West offices has remained on throughout the meeting, so hopefully another step forward in hybrid and virtual meetings. Thank you all for your time, much appreciated, and I'll see you all, I'm sure, at that next meeting. Thanks all. Bye-bye.
Live stream's now ended.